Good afternoon, everyone. Good day, wherever you are. A really big, warm welcome to you all to the WeMove Adolescent Health webinar, which is hosted by the Desmond Tutu Health Foundation and IRV. My name is Luann Hatani. I'm the Executive Director at Pediatric Adolescent Treatment Africa, PATA. And I'm going to be chairing today's session with you all. And thank you so much for being here with us. And we look forward to an interesting and interactive time together. This is the 6th webinar in this year's WeMove series. And today's particular focus is going to be on peer support interventions in adolescent and youth programs. We have some fantastic presenters, Dr. Wole Ameyan, Mr. Chris Barkley, and also an autistic item from Zizi Mazana, who are then going to be followed by a panel discussion with Carol Wogrin and Jean-Peierre Zeelie, who I'm going to introduce a little later. But before we get going, and before I introduce everyone, just to start the webinar off, we just would like to invite you all to participate in a poll. So if I could all please ask you to answer just one very quick question, which hopefully will be coming up on your screen anytime now. There you go. So youth living with HIV that are struggling with treatment adherence are better supported by, and you have 4 options: adults that are also facing treatment challenges when they were younger, or a clinic nurse who knows the implications of non-adherence, peers who are currently managing their treatment well, or community outreach teams that visit young people at home. We're just going to give you a few seconds. If you could please select one of those options. Great. I'm hoping our technical support will be able to give us an indication. There we go. An overwhelming majority of people clearly think that peers who are currently managing their treatment well are the best support in terms of their own peers in relation to adherence and obviously just on this navigating a journey of being a young person and living with HIV. So I think we can see other cadres of health providers still, important, playing a role, but absolutely, essentially is the role of young people themselves. So thank you so much for that. We're going to be moving on and getting started with the sort of formal part of our webinar. And I think our first, and to get going, to introduce you to our first speaker, which is Wole Ameyan, who is a trained doctor. He holds a master's in public health and leads the adolescent HIV work at the World Health Organization headquarters in Geneva. He has over 10 years progressive clinical and programmatic experience working with government ministries, intergovernmental agencies, NGOs, and communities. And for all of us who know Wole, he's a strong advocate for the meaningful engagement of young people living with HIV. And he's going to be presenting today on peer-driven models of HIV care, tapping the strengths and unlocking the opportunities. So over to Wole. Thank you.
Thank you so much for the invitation, and I am really delighted to be part of what is becoming a very popular brand now, the WeMove webinar series, where we have the opportunity to discuss topical issues around adolescent HIV and adolescent service delivery. My name is Wole Ameyan. I am the Adolescent HIV lead at the World Health Organization in Geneva. Today's webinar is so important, and it's why when I got the invitation to speak, I grabbed it with both hands, because when you look at all of the indices and the indicators that we have, globally, but even more so in Africa, we have huge gaps on adolescent treatment, but quite frankly, not just treatment, but adolescent across the cascade of HIV, from prevention to testing, to treatment, and to virus suppression. One quick one that we can look at is ART coverage. We know that adolescents and young people have the shorter end of the stick when it comes to accessing treatment, and usually the reason is it depends on where you are and what you're listening to. Some people believe that the reason is about political commitment, but I'm not quite sure about that. I think the reason is not really about political will or commitment. It's about action. It's about how we deliver all of the services that we have, and there's so many of those, across the cascade. It's about adolescent-friendly services and how we bring those services to young people. The topic, of course, today is linked to that. So peer-driven models of care. Those are at the heart of what I feel is the reason why we still suffer a lot of gaps on adolescent HIV. Peer-driven models, of course, are absolutely fantastic. And my presentation would give an overview of some of the work that we at WHO, working with partners, do, but also some of the main factors that we need to unlock the strengths and the potentials, and there's so many potentials, like I'm sure you all know, of peer-driven models. I'll start by saying that peer-driven models shouldn't be looked at in isolation. We always must go back to the base. We have to get the base right. The base, of course, is adolescent-friendly health services, of which the concept and the drive and the values of peer-driven models are a part of. You will recall that in 2016, WHO published, that landmark recommendation. It's you look back now, you think, wow, that was really the driving force, passing that recommendation on providing adolescent-friendly health services for young people. But beyond that is all of the values that come with it, and below you see what it means, the characteristics of adolescent-friendly health services. I think these bear repeating, because sometimes we go into providing services, into engaging without remembering some of the core values and principles behind what we do. The first of course is on equitability, making sure that when we provide services and when we birth models and try to cascade models, it isn't just for certain groups of adolescents. It's adolescents across board, and as they need those services, adolescents, even more vulnerable adolescents, pregnant adolescents, adolescent mothers, young key populations, and so on. The equitability of services is absolutely important. Of course, making sure that beyond having those services is to make sure that they are accessible and acceptable to young people in a way that meets the expectations of young people and adolescents. And this was why, of course, For those of you who know how WHO makes their recommendations, one of the core pillars of arriving at a recommendation is of course, what we call the values and preferences. We need to go back to young people and say, do these make sense? Are these acceptable to you? How do you feel about this? In a way that makes sure that, we provide the services in an acceptable, in an appropriate way, but also effective services, making sure that those services work and that they provide a positive contribution to the health of adolescents. You will see to the right of the screen the global standards of providing these adolescent-friendly health services. Of course, there are 8 of them. There really is no need to go through all of them, but I'll just harp on standard 8, which then delves into my presentation on peer-driven models. Standard 8 is on adolescent participation. I mean, there's so many standards here. I implore you actually to if you can, have a look at these standards. There are many countries who are adapting these to great effect in countries. But standard 8 is on adolescent participation and making sure that adolescents are at the heart of services that belong to them. On the next slide, I think it's important as well. When I started, I mentioned the interest. There is a global interest. If peer-driven models are not doing well today, it's not for a lack of interest. It's almost become a fad now. Every other proposal that I review for funding, has an element of these models. Okay, we want to involve young people. We want to make young people drive it. It's becoming, very fashionable because it's nice. It's good to hear, but sometimes the taste of the pudding is in the eating. You need to go delve deeper to see, are these really what we mean when we talk about peer-driven models? Are the principles being adhered to when these are being done? And I think really it goes back to doing it for the right reasons. Why? Is it because it's nice? Is it because it's good to hear? I think we need to go back to the base of it. The fact of the matter is that peer-driven models, and the strongest rationale for engaging young people and for these peer-driven models is steeped in science and in human rights. There is now a very good body of evidence that engaging young people leads directly to improved health and well-being outcomes for adolescents and young people. But beyond the health outcomes and beyond the well-being outcomes is the right of it. It is a right. The rights of young people, including adolescents, to take part in essentially what is their own. It affects their lives. I don't need to tell you that these rights are enshrined in the United Nations Convention on the Right of the Child. Of course, this was, for many of you who know the CRC, in 1989, this was absolutely enshrined in what we all should be doing. I refer here to a WHO technical brief. It's on adolescent empowerment and engagement for health and well-being. You would see the pathway actually for how adolescent engagement to health and well-being leads to all of those improved outcomes that I mentioned. So really important that we take this on board, that adolescent engagement and well-being is a right, and it leads to a sure pathway to reaching our targets, including the Sustainable Development Goals. So on peer-driven models, like many of you know, WHO has been at the forefront of extending the frontiers of peer-driven models. I think already we've had fantastic work being done, across countries, by partners, implementing partners, ministries of health, and at WHO, working alongside, partners. We've been, trying to, provide support to extend these beyond where they currently are into other spheres. On this slide, I highlight two important areas of work on policy development and research that we currently do. Together with UNICEF, we led the development of a technical brief that highlights concrete, practical examples from the HIV response of youth-driven peer models of care, which have proven to be very successful. You see to the right of my screen the very nice picture on that brief. I might not be able to go too deep into it, but have a look at this. In it, we highlight some of the bastions, the flag bearers of these peer models. There are 5 of them that you would see in this brief. They need no introduction really, but the Jandiri model, famous, everyone knows about this. It's started in Zimbabwe, moved to other countries as well. Operation 000, supported by PEPFAR and our colleagues at CDC, the aerial clubs with EGPAF, the BIPAI teen clubs with Baylor, the REACH model with my very good colleagues and friends at PATA. These are models that have shown what is possible and what can be done when implementing peer-driven models of care, and models of care that can be led by young people, by adolescents, towards making sure that they receive the services that they need and that they deserve. In that technical brief as well, you would see a lot of information about these models, these 5 models, and I'm just using those models, not to say that they're the only ones. There's so many others as well. But these are models that you can look at and see the work that they have done, the efforts that they have put in, the absolutely incredible sweat and commitment that has been put into these models to be able to put them forward to countries at large. But of course, it goes beyond just having the models. It's impossible to start or sustain these models without putting in work. The title there says you cannot wish this into existence. So there are, of course, considerations, including training, mentoring, quality improvement that need to be put into these models to make them work. Of course, there are other enablers, programmatic enablers on making sure that the countries, the ministries of health are part of it, and that they are done in line with the global standards that I've just mentioned earlier. As I round up, there are just 2 slides that I need to just make a pitch on as well. For the models that I've just mentioned, those 5, but those others as well, what makes them tick? For people who are listening and thinking, okay, I would like to start a project on peer-driven models in my country, in my district, the 5 things that you may want to look at that makes those models what they are. I have acronymized these as F's. So we have the 5 F's. The first is facts. So facts are facts. You can't belabor facts. All of those models have been able to go put their work into papers. They've written, they've studied, and they've published. So that's one of the things. We have to be able to deal with the facts of what you're doing. Try to write even if it's an opinion piece. Collect data on what you're doing and make sure that what you're doing is evidence informed. The second is fusion. You would find that these models do not just focus on a part of the HIV cascade. They don't even focus just on HIV. So you'll find prevention, there's testing, there's treatment, there are interventions on adherence and virus suppression, but even beyond. There are models that look at integrating HIV with non-communicable diseases, with mental health and so on. So there's that fusion, which is the second F. The third is flow, which is making sure that all of the different programs, who have, you have HIV, you have mental health, you have NCDs. There is a coordination that needs to go with that. There's referrals. So we need to make sure that there's effective coordination to ensure a seamless flow of these different interventions. The fourth is on facilitating learning, scaling, and improvement. With my friends at Jandiri, this is something we do really well, and always we try to come on webinars. There is the Tele-Echo webinar series that we use as a platform to learn and to share and to make sure that we have the sort of improvement that is necessary for these peer-driven models. And then finally, of course, the last F is on fostering the meaningful engagement. When we say peer-driven, it has to be peer-driven. There's so many differences between peer-driven, peer-led, peer co-led, peer-engaged, peer-involved. I think you need to be able to speak very clearly to what you're doing, and the name of it needs to bear fruit with what is actually being implemented. In terms of implementation, there are also just 5 things I would like to highlight on making sure that these are implemented in the right way and to scale as it is needed. I've also acronymized this with S's, so there are 5 S's. The first is about scale. Really important to move beyond current geographic areas, to spread it, reach young people by frequency, by geography. Moving to scale is really important in what we do. The second is substance. I alluded to these earlier on, to say that, a lot of the time we talk about peer-driven models and it's just by mouth. There has to be substance to it. We need to move from, the bandwagoneering and the sloganeering and, focus really on what the crux is, which is making sure that young people are at the center of their own care. The third is on subpopulations. Again, I alluded to this earlier. We need to reach out to adolescents in all their diversity, in all their heterogeneity. Young key populations, adolescent boys, adolescent mothers, pregnant adolescents, they need to be reached with these great models. Synergy, of course, is very important, linking and referring. We can't do everything, so we need to be able to link, ask for help as it is needed. And then finally, on sustainability, I couldn't say more on this. It is important that as we implement, we take advantage of enduring structures, national structures, to ensure sustainable peer-driven models. The final slide is on unlocking the opportunities and dealing with what's next. There's so much that has been done, as you've seen in some of my slides, but as you will see in some of the presentations that will come on after mine. But I mean, there's still more that we can do in terms of bringing forth data. So I would say that there's still a few gaps. The paper that I shared on one of my slides on peer support highlights some of the data gaps that we have. I think this is something that we need to take seriously. The second is moving forward. Despite data, we need data, but we know that these work. So we need to move. WeMove is the theme of this webinar series. So we need to move forward with purpose, with clarity, with intention, as we scale up these peer-driven models. Thirdly is on making sure that we have differentiated models for differentiated populations. All of the populations that I mentioned earlier, there should be the what, the who, the how for these different populations. I cannot say enough that we focus too much on facilities. We need to be able to move beyond that, extend to communities, and also moving from physical to virtual. We've seen what COVID-19 has shown us. We need to be able to take advantage and unlock the opportunities of the virtual world in a safe way, the safe space for peer delivery of services. And then finally, I am an advocate of integration. I am an advocate of meaningful integration of services. Let's use the opportunity that we have to integrate to other services, mental health, STIs, HIV cascade, all through the cascade. Let's use that opportunity. So I'm going to end there and just say thank you again to the organizers. For everyone listening, please, happy to hear your thoughts, your questions, your suggestions. But really, I would like to know from you, for my own work, what do you think WHO and the global community as well should stop doing? What should we continue doing, or what should we start doing to advance peer-driven models of care? I'd like to say thank you to the WHO Adolescent Service Delivery Working Group. We have a fantastic young person who helps a lot of the work in this group. I'd like to just certainly thank Cindy and others who continue to contribute to this group, and of course to all of you, amazing young people, adolescents all over the world, who lead these peer-driven models. I think you're such an amazing example to all of us, and I'll just say let's keep going, and we're gonna get there. Thank you so much.
Great. Thank you so much, Wole. I mean, I think a really good reminder that peer interventions are really part as well of a broader package of comprehensive adolescent-friendly services. And of course, as you highlighted, young people remain at the heart of that. I'm not going to go into questions now because that's going to be part of our panel discussion later. But just apologies, I had forgotten earlier just to remind everyone, please, to either use the chat but also the Q&A button at the bottom. If you have any particular questions for one of the speakers or the panelists later, please, if you could please note them there so that we could make sure that your questions are addressed as we begin those discussions. Before we move to our second presenter, I'd like to welcome Zizi Mazana, who's a Cape Town-based yoga instructor, cultural and theatre worker, who's going to share narration and poetry based on personal experience. So over to Zizi. Thank you.
Hello. Hi, my name is Zizi. I am a yoga instructor, a cultural worker, and a theatre maker based in Cape Town. Today I'm going to be reading an excerpt from a poem I wrote recounting my experience of sexual assault in Cape Town. In truth, just as every other evening I spent tugging for your affection in your home, or our home, as you had prematurely announced weeks prior, I don't know what song we were bopping to. But you, my lover, your lover, their lover's friend, friends, and family were gleefully entranced by the percussive bass lines of the Llanos. I also did not know that you, my lover, your lover, their lover's friend, friends, and family would within hours be in attendance of my assault. The story goes, as narrated to me by you, my lover, in the absence of your lover, their lover's friend, friends, and family, nearly 36 hours later. Yeah, hey, I don't know if you remember what happened. So, my lover, after I had questioned you about the scratches on my elbow and the bruise under my right eye, as I said last night when I texted you, I don't remember much about the night before, I responded, annoyed by your prioritization and preoccupation with the pictures I posted on IG earlier. You were raped, eh? You continued. I tried to push the toilet stall door, but the guy was very aggressive. I think you were raped, basically. What? I exclaimed, naturally, and the confusion of what had happened to me was compounding. Although I was flooded with questions and perplexed at the delivery of this news, I was embarrassed. Embarrassed that I had put you into that situation, so I apologized. I am so sorry I put you in that situation, and I am so sorry I behaved this way. After the phone call, I turned to our lover, confusion compounding and unable to comprehend. Huh? What state was I in? Why didn't you reach for help? Call your lover, their friend, friends and family. In a club full of people, you could not reach for anyone? Fuck, bro, the bouncer, 10-1, an ambulance. Why did you not tell me sooner? What about my sexual health? Nearly 42 hours in, my response, feeling disgusted and disappointed by you, embarrassed by the situation, was to shower. The following morning, I collected all my coins and I missioned to the pharmacy, nearly 50 hours after the fact. Fuck, I did not budget for this. It is at Clicks that I learned that the fever, tiredness, headache, and shortness of breath were not the compounded shame of having inconvenienced you, my lover. Not only had I been raped, this man had given me COVID. At Clicks, the pharmacist kindly expressed her concern for me. Once I recounted your narration of what had happened to me with genuine care and concern, she redirected me to Grooteskier Hospital, where I spent hours, again, relaying your narration of my assault. 60 hours later, here, I became aware of the protocols and procedures of reporting an assault. I was deserving and entitled to victim support. Pressed for time and fearing I wouldn't receive the necessary medical support within the 72-hour period post-assault, I was sad that neither you, my lover, your lover, their lover, friends and family offered or thought to extend me this grace. Redirected from Grooteskier to Victoria Hospital's forensic unit with less than 10 hours left, again I was asked to recount your narration. I did not have a statement to make. All I knew is that I was raped. Ityala lona, the nurse stressed from the passage on the other side of the burglar bars at the forensics unit. You will have to wait for your COVID test results before you can do a rape kit. Can I please get medication, something? I pleaded, before she even re-emerged from a door in the passage on the other side. When she neared, she passed me a parcel. In it, pep, antibiotics, a morning after pill, and something for the nausea. As she explained what each was for, and asked again, Ityala, lona. All I could think was the only witnesses were you, my lover, him, my perpetrator, and the yellow jumpsuit, your yellow jumpsuit, you had helped me change into before we left for long. Thank you.
Great. Wow. Thanks, Zizi. I mean, just what a huge, powerful reminder on the very painful reality that so many adolescent girls and young women in our region face. And just a really, huge gratitude to you for sharing your personal story and showing us, I think, how the lived experience through poetry and art can really be transformative and really help, especially many of us working in health services, to put a human face on these very real barriers and challenges experienced when really needing the care and support one needs when accessing services that should be available and supportive. So thank you so much for that. Moving to our next presenter, I'd like to introduce you to Chris Barkley. He's a technical advisor for mental health services at Grassroots Soccer, and he leads Grassroots Soccer's adolescent mental health strategy and programming. He's held multiple roles at Grassroots Soccer in the past, in both business development, partnerships, and training. And he's going to present today on Grassroots Soccer's adolescent mental health strategy and focusing on integrating mental health into an adolescent health organization. So over to Chris. Thank you.
Hello everyone, this is Chris Barkley from Grassroots Soccer. I'll be presenting today on our adolescent mental health strategy, talking about our programming and looking at how we've integrated mental health into our organization. It's a real honor and privilege to be here. I will provide some background on Grassroots Soccer and our approach, and then go into our adolescent mental health work and give you examples from peer interventions that we run. So this is our mission statement. If you haven't come across Grassroots Soccer, we're an adolescent health organization using the power of soccer to educate, inspire, and mobilize youth to overcome their greatest health challenges, live healthier, more productive lives, and be agents for change in their communities. We started in HIV prevention in Zimbabwe in 2002, but we have broadened the scope of our work over the last 20 years to include a number of health topics, including sexual and reproductive health, and most recently, mental health. So core to our work is our approach. This is a simplified version of our model. We call it the 3 C's. This is curriculum, coaches, and culture. So we have a methodology for our curriculum looking at social and emotional learning and play-based methods. And we use that approach for any health topic that we're covering. Our coaches, these are our near peer mentors. They're sort of the core of our work. These are young people from the communities in which we work, and they are the ones that are connecting to young people and also modeling positive behaviors and relationships, inspiring young people to take action. And then the last bit is our culture. And so this is how we create a fun and safe environment that is really important for talking about sensitive topics, for learning, for sharing. And so I'll talk a little bit more about how we've applied this to mental health. So we do a lot of work with young people living with HIV, and this is one of the quotes that really captures why we've gotten into adolescent mental health work. So this is a quote from one of our coaches who's living positively with HIV. And I'll leave it up for a second, but the idea is that they felt that their health had been flattened and simplified to mean being virally suppressed and not looking at other aspects of their health. And that's not how they saw themselves or their health. In addition to anecdotes from young people, from listening to what young people were experiencing and needing, we also looked at what the data was saying around mental health, adolescent mental health. And these were some of the data points that really stood out to us. So mental health and substance disorders are the leading cause of disability among young people. They account for nearly 50% of the global burden of disease in the first 25 years of life. As we can all relate to, COVID made this much worse. Some estimates are that the prevalence of depression and anxiety have doubled during COVID-19. Young people in sub-Saharan Africa are disproportionately impacted by poor mental health. This is one of the challenges, that there is not good epidemiological data, but 2021 systematic review of studies in sub-Saharan Africa found much higher prevalence of mental disorders among adolescents than the global average. And some of the reasons would be the social and structural drivers of poor mental health, poverty, violence, unemployment. So adolescence is a key time to intervene, and there's evidence that early detection and treatment of mental health challenges have long-lasting and multiplier effects. 75% of mental health conditions onset by the age of 24, and the physical, psychological, and social changes that occur during adolescence are essential to promote good mental health. Despite that, and unfortunately, the response to child and adolescent mental health is alarmingly inadequate. Only 3 African countries have a child and adolescent mental health policy, and funding for child and adolescent mental health services, although there's not good data, tend to be less than 1% of most national health budgets. And one of the byproducts of that is there is really low levels of mental health knowledge and a lot of stigma that reduce care-seeking behaviors. Poor mental health has serious implications for other health challenges across the life course. It's linked to long-term negative health, education, social, and economic outcomes, and suicide is now the 4th leading cause of death among older adolescents globally. And although some effective mental health treatments exist, the supply is totally insufficient to address the scale of the issues that we're facing. And most young people never get the mental health support they need, and this is called the treatment gap. Estimates are that something like 90% or more of adolescents with mental health conditions in sub-Saharan Africa will never access care. So our conclusion, after reviewing the data and thinking about what we could contribute to, is that there is really an urgent need for community-based adolescent mental health promotion, prevention of mental disorders, and early intervention. So we came up with this is a simplified theory of change. These are our goals around mental health for young people. And so we really want to make sure young people receive mental health education and services early, and that lays the foundation for lifelong mental health. And so our education and support, we've broken down into these areas here: knowledge, coping skills, stigma reduction, care-seeking behaviors. And for young people that are experiencing some common mental health conditions, we also look at symptom recovery and reduction. And ultimately, we hope that improves mental health for young people, and that improved mental health has a bidirectional relationship with a number of other health outcomes. So in response, we have been developing mental health programs, and these are differentiated programs and products. Mental health is on a continuum, and so we're trying to respond to different needs along that continuum, also looking at different formats and different settings. So one is integrating mental health concepts into our existing programs. That could be as simple as having a session on what is mental health within a HIV prevention or sexual reproductive health program. But we've also developed our flagship mental health promotion program. These are dedicated mental health programs, and we have a curriculum, a training manual for community health workers or educators, and also a magazine. And the third piece here is our educators, our mentors. We call them coaches. We've also been building their capacity and testing models around group therapy for young people experiencing depression, and making sure our coaches have the knowledge and the skills to identify and refer young people to more specialized care. I'm going to try to bring this to life. It's hard over the screen, but this is an example from Mind Skills of a practice called balance and stress. And so we try to use games and activities to bring these ideas to life. And so in balance and stress, participants learn about the stress response and discuss coping strategies that they can use to alleviate stress. So in this game, the big ball, the soccer ball you see there, is representing a healthy mind. And over time, we introduce different stressors, and young people talk about what are stressors that they have to deal with in their lives. And then we have these ideas that stress isn't necessarily bad, but too much over too long starts to damage the healthy mind. And then we talk about different ways to cope with stress, including talking to each other when we need support. In addition to specific activities around mental health, we've tried really hard to build positive mental health into the structure of all of our work. And that includes things like really routine warm-up and cool-down procedures. And our warm-up and cool-down procedures have things like coping techniques, such as breathing techniques. We do group and individual check-ins. We have things like winning words to build emotional vocabulary. And we use this very specific type of debrief called Feel, Think, Do, where we try to make connections between feelings, thoughts, and actions. This is an excerpt from our magazine, and this is a take-home mental health material that combines soccer and games and information. And one thing that's really nice is that young people can share this with people in their household or peers. And then we have a lot to learn, and we're just getting started. So we have a number of evaluations ongoing, and one that's completed. Each one has a slightly different question that we're trying to answer. And I'm going to leave this up for a second. I'm at the end of my time, looking forward to questions from the group. Thank you so much. It's a real honor and privilege to be a part of this panel.
Thanks so much, Chris. I mean, I think just importantly, we can see that mental health is just center stage of everything. And then in working with adolescents, the integration of mental health has to be across the board, and the significance of mental health and well-being in the provision of adolescent-friendly services. There's been one mention in the Q&A that the chat function hasn't been activated. I think that will now be activated after that presentation. So it should be available now. So to the person who answered or who asked that question, please do try now. I'm keeping abreast of the questions. But that takes us really into the next segment of our webinar, and that's really around that panel discussion. So I'd like to introduce our panelists, and I'm going to ask sort of all of our panelists and the presenters if they wouldn't mind sort of all joining the discussion and putting their cameras on. So introducing our panelist, Carol Wogrin, who's a clinical psychologist at the Jean-Peierre Peer Counseling and Adolescent Care and Support Program at Africaid in Zimbabwe, as well as Jean-Peierre Zeelie, who's a Senior Technical Advisor at Mothers to Mothers in South Africa. So thank you both for joining. And before we bring our presenters back on and part of the panel, I just wanted to sort of reach out to both of you, and maybe first to you, Carol, and then to Jean-Peierre, just from the earlier presentations, some of your sort of key takeaway or reflections from the two presentations that have been shared, and then we will go into the question and answer segment. So over to you, Carol. Thanks.
Thank you. And again, thank you. It's wonderful to be part of this. So I think this whole topic about adolescent-driven initiatives is timely and important. And I think some of the pieces that really stood out to me in both presenters that I think are really important to emphasize is the importance of quality implementation with adolescent-driven and when we're having adolescent counselors, mentors, be the primary service providers, is the importance of the training for them, the ongoing mentorship to ensure substance and quality. And I would just want to add that along with training them and mentoring them and providing the counseling and mentoring to their peers and supporting them in that, as organizations, the responsibility that we have, moral and ethical responsibility we have to the adolescent counselors and mentors themselves. They're dealing with really difficult issues, as we heard, the mental health issues, etc., in their peers. They are living with the same challenges that the peers they're supporting are. And I think we need to keep that in mind and keep it kind of forefront so that trainings aren't one-off. They don't go without mentor support themselves. And so again, I think just to really emphasize the responsibility we have to these young people who are working so hard and taking on such responsibility as they support their peers.
Thanks, Carol. Yes, I mean, hugely important. I think the significance of the responsibility and the consideration that needs to be taken. Jean-Peierre, could I hand over to you just for some of your initial reflections and thoughts?
Sure, and perhaps I'll build on what Carol had outlined. You know, I think I really appreciated in the first presentation the real practical steps that were outlined, and you know, how to tangibly take it from theory to practice, as one of those slides was outlined. And the reason I say this, because as we should do in public health, you know, different interventions have been scrutinized. And in recent times, there was a really wonderful paper by Dr. Chandra Nugmuli from, he's the WHO lead for ASRHR, so Adolescent Sexual Reproductive Health. And he looked at what doesn't work in sexual reproductive health programming. And one of the pieces that took away was peer education to encourage safer sexual behaviors for adolescents doesn't work. And that opened up the question around, what do we mean by peer education? What do we mean by peer driven? What do we mean by peer support, peer mentorship? And that was one of the questions in the chat as well. And it really came down to saying, you know, if we just look at a standard peer education model, perhaps of how we did it yesterday, it would necessarily only benefit the counselors. There was a limited retention of information as it got cascaded down. And we really need to introduce the quality programming aspect, which Carol outlined, having more robust kind of supervision, job profiles of the adolescents themselves. And you know, I think that's really important. And one of the pieces too, just kind of leading into the second presentation, was saying what WHO has also touched on recently is around the importance of psychosocial support in a peer support model. Recognizing, you know, if we're going for a peer-led approach, where we've got our peers that have aligned age matching to those that they're dealing with, they've got similar life experiences, they're from similar communities, there's a huge mental health burden in the work that they do. And we need to look after them as almost our first line of support, is our first line of patience. And only once we protect them and provide adequate support for them can we really look beyond that. So just a few thoughts around the Grassroots soccer presentation, which is equally excellent. You know, I think what I really appreciated was a really tangible piece around how this is a peer-driven support model that works. We also need to look at the fact that, as we said, you know, social norms, it's a huge piece, depression being one of those, of how it's approached within the communities, within families, and really understanding that with adolescents, those norms are, they start to really become firmed up in the early adolescence phase. So we really need to have these interventions that start on the early adolescence piece of the age cohort. And there's no better place for that than in schools. You know, we know that there's 3 times as many schools as health facilities in sub-Saharan Africa. So that's an ideal entry point to start these types of interventions. And I'll stop at that. Thank you.
Great, thanks. Thanks, Jean-Peierre. I wonder if I could invite Wole and Chris to join the panel as well. I can't see them. Maybe they are there and it's just from my screen
I am here
that
now.
I can't
Hello.
see them. Oh, there we
I'm
go.
here.
We can see you in your car. Very cool. I'm not sure if you're in Cape Town. Hopefully you don't have as much wind as me, but great. Thanks for joining us. I'm not sure, Chris or Wole, any additional thoughts in terms of just building on what Carol and Jean-Peierre had shared? And then Wole, just there was a very specific question which I think has already begun to be answered, which is really just trying to understand or distinguish a little between, you know, when we talk about peer-driven, peer-led or co-led, you know, what are the sort of benefits or, you know, on these different strategies? Is there any evidence to suggest one above the other? Maybe it's a combination of all of those, but just if we could hear your thoughts on that. So maybe just over to Wole to answer that and to build on what's already been shared. And then I'll go back to Chris. So Wole, if I could hand over to you.
Yeah, thanks, Luan. And you know, actually, I sort of preempted the questions, you know, in the chat box, but also what Jean-Peierre has mentioned, and that was why, you know, from the offstart, I felt it was important to, you know, bring forth all of those terminologies and, you know, try to see if there are, you know, first of all, distinctions and if there is evidence to support one over the other. So in my presentation, I had mentioned, you know, peer-driven, peer-led, peer co-led, or just peer-involved or peer support, you know, education types like Jean-Peierre mentioned. So I think what distinguishes what was mentioned on just you know, the basic old peer education is that would, you know, usually tilt towards information, so information sharing. Now we know that just giving information to people, yeah, it could increase their knowledge, but it doesn't necessarily change you know, any behavior. So I tell you about condoms or about ART. I mean, you could have that information, but I think what really matters is if those that sort of information then transforms into use and action. And I think that's what you know, Chandra was sort of mentioning there, to say, you know, just education or information really doesn't change. However, when we go further down that ladder and we begin to talk about peer-led, peer-driven models, those go beyond just information. And I think this is where the other presentations that you've seen, but also when you look critically into the amazing work that, you know, the likes of Jandiri, you know, the REACH models, what they do is that they go beyond the education, beyond just the information and the education. There is, you know, support being provided. There is navigation, and so on and so forth. And the navigation and that support that peers give to each other, those have been shown to actually improve, you know, specific HIV outcomes. You look at 2016, you know, right from 2016, but even coming down to 2021 guidelines from WHO, the navigation from peers, etc., and all of the sorts of support that they provide show improvement, you know, in adherence, virus suppression, and so on. But beyond the guidelines, you would see from the specific models, and maybe you know, others on the panel can speak to this, how those models that are peer-led, peer co-led, and the sort of support that they give have led to you know, great outcomes on HIV.
Great, thanks, Wole. There are questions sort of coming in the chat, coming in the Q&A, so I'm just trying to keep abreast of those. I think I'm picking up sort of some themes, so I'm going to sort of hold those because then hopefully, that could just bring us all into one conversation. There was a very specific programmatic question, so I think I'm going to try and address that one first and then go back to some of the more thematic questions that are emerging. So Chris, there was, I think, one that's specifically focusing on the 3 C's, if I'm reading correctly, which was really just a question around whether both genders in terms of the peer supporters are engaged in that. So if you could just give a little bit more clarity to that particular question, and then I'll try and move us to some of the more thematic questions and discussion. Thanks.
Yes.
Yeah, thanks. Oh,
Go ahead, please.
Oh, sorry, maybe that was to Wole. Sorry. Oh, no, the 3 C's I thought was Chris, but maybe I got it wrong.
Yeah, Chris, you can go ahead, Chris.
Yeah, thanks. It's a great question. We have both. We have programs that are mixed sex. We have programs that are single sex. So yeah, it just depends. We found we're just starting now for the last 18 months to deliver interpersonal group therapy to young people that have screened for depression. We found that single sex groups have been working really well for that. We also have some programs focused on gender and sexual reproductive health, and there are moments when those are really effective in a single sex setting with a same sex peer facilitator, but also lots of important times to bring both sexes together. So I know that's, I don't know if that answered it. So yeah, the 3C model is not specific to a certain gender.
Great, thanks. Thanks for that. Wole, did you want to, yep?
Yes, I wanted to just, I think it was Sia. Sia was talking about the 5 S's that I mentioned in my presentation.
Ah, okay.
And, and she says, do they apply to, she says both genders when implementing peer support. So that's the question in itself. So to answer that question, I will refer to, I think it was my second slide, when I was speaking about, the principles and the values of providing adolescent-friendly health services. And one of the key things, and which I think answers that question, is about equitability, making sure that we are not, speaking to or implementing for just, particular groups of adolescents, but actually this should go to adolescents of all genders, all sexes, whatever you would classify it as, but it is about providing those services for all genders and as they need them. And I think that's important to highlight here, that we have to make sure that there is no as well discrimination, stigmatization, which we know are really core issues that limit what we're able to achieve with these models, and even globally. We must begin to make sure that that the services are as widespread as possible and as needed for adolescents, irrespective of whether they're younger or older, irrespective of their genders or sexual orientation or geography. I think it's important that we put this really in that context and we deliver those services with platforms that are broad enough for adolescents to uptake the services that they need.
Great, thanks for that, Wole. Also, just to our participants, I mean, you get to see all of us. We don't get to see you, which is not always as fun. So there has been a message in the chat that if you would like to sort of join the panel, or please just raise your hand, and those supporting the technical side of things will be able to put your camera on and give you permission to unmute yourself. So please do that if you would like to join the panel at any point. I'm going to sort of move a little. There have been one or two questions. There's a few questions, or one question particularly sort of around, I suppose, attrition and the sort of question of like aging out. So I think maybe, you know, we could look at that for a little bit. And then I want to move a little bit more towards this, you know, big focus, you know, on this responsibility of mentorship, supervision, and then sort of the actual mental health of the peers themselves. So then I think we could maybe move to that aspect. So I think I'm going to ask just each of the panelists and the speakers, just, you know, and maybe starting with Carol, given the experience of Jandiri particularly, but just the, you know, how do we prepare for sort of aging out, and also, you know, when there may be sort of turnover and attrition of young people, especially when their peers, you know, become quite reliant on them or have established a close relationship, etc. So just from your experiences, and then I'll hand it over if anyone else would like to build on that. Thank you.
Thank you. And I think the issue of attrition is an interesting one when we're working with adolescents. And I think we have to think about it in two ways. One is that it has to do with the responsibility we have to be supporting them, hearing their issues, responding to them, and providing them the kind of structural support in doing their work. The other thing we have to do is keep in mind they are adolescents. They are at a time of life where they're moving into new areas in their life, sometimes becoming a peer counselor, getting appropriate, you know, having the opportunity to really help their peers. It builds their self-confidence, it builds their self-esteem, and it helps them develop their goals. Oftentimes, some of the attrition, or sometimes much of what we see, is them choosing to move to new areas, in part, you know, as they think about their things and about their lives and what they move into. And I actually just saw a comment come up from Nicola Willis, Jandiri, executive director, and an important point. It's important to think differently between graduation and attrition. And so the ones who are dropping out versus the ones who are graduating and going to new things. You asked about how we prepare them. I think it's important that we really give a lead up time, both in helping them address the issues with their peers. Oftentimes they bring in and connect with our CATs, our community adolescent treatment supporters, connect their clients or beneficiaries with other CATs, do some work jointly so that there is a transition to another relationship. We support the CATs in saying goodbye, and then also helping them prepare to think about what they're moving on to, thinking about helping support life skills development. Oftentimes, you know, going on, they're supporting themselves, their families, and so really helping them prepare for the next stage of life. So I think we have to think about the transition, the graduation, kind of from a multi-factored way.
Great. I mean, I think just, yeah, you know, super important to clarify the difference between graduation and attrition. So, I mean, I think that's really helpful. Maybe Jean-Peierre, Wole, Chris, any additions to that just from your own experience? Anyone want to, Jean-Peierre?
No, I agree. I think just to build on what Carol said, also as it was mentioned, the adolescents will age out of these groups, and when we work with the peer support model, at least with the mothers to mothers, we identify those that are seen as vulnerable or high risk, and those that decide that want to be in our program and benefit from the program. And as we know, with adolescence, it's a time of great change. It's a time of what's they call, like, by monetary independence. Many adolescents want to move to urban areas to find jobs. So we know that the many kind of concerns that are presented to them, HIV is perhaps just one of them, and it's around perhaps teenage pregnancy and livelihoods and anything else that they're trying to kind of set themselves up for later in life. And we have seen that adolescents, once they start to see HIV as perhaps a manageable condition, they'll drop out the program and move on, and once their vulnerability rating kind of it strengthens to the point that they may no longer require the services that we're providing. And then we look at identifying new peer mentors that come through the program, right? So existing clients, as we call them, that show the role modeling abilities or show that they can manage these conditions, and we can set them up to be employed through the program and share this knowledge and support to other adolescents in their communities.
Great. Thanks for that. I think before we sort of move on to the coaching supervision, Wole, there was a question for you from Chelsea. I wonder if you could just speak to that, answer that live. I mean, it's really talking to the 5th F, which is around sort of meaningful engagement of young people. And could you give an example of how this was implemented well and also measured?
Yeah, thanks, Luan, and thanks to Chelsea for the question. I think there are actually on the 5th F, there are quite good examples of models implementing that 5th F, and that's why I was actually going to post the brief on moving from theory to practice on that particular question from Chelsea. So there we have looked at 5 of what we had as peer-driven models. Of course, the Jandiri model, Operation 000, the reach from PATA, aerial clubs with the EGPAF, and the teen clubs with the PI. And those are examples that you will find in that brief on what they have done with implementing the 5th F on engaging young people and making sure that, when we speak about peer-driven, it really is peer-driven. It's there is nothing wrong with the other approaches. So whether be it co-led or led and so on, but the point is that it's important that when we say and we put forward certain ideas, we need to be as well true to those ideas. And in that brief, which I'm going to post in the chat, Chelsea, you would find those examples of those 5 models and how and the how, which is what the question is of how it's been done.
Yeah, thanks, Wole. I mean, maybe also just building on sort of Chelsea, and not to take some space in the panel myself, but maybe just to share. I mean, I think in several of the regional programs, I can speak a little to the READY program, of which we partner with Jandiri and several other partners in the region. I mean, I think one of the things is really beginning to sort of, within the programs, to look in different spaces where young people are being meaningfully engaged. So obviously in peer support, we see they're being meaningfully engaged as, delivering a service. But we also know in many spaces, young people are also monitoring the services. So, we have something called the Ready to Care scorecard, where young people are actively not just monitoring and sort of reflecting on the services and how they experience the service, but they then sort of come back into, a quality improvement plan with the health facility and with their community partners to begin to sort of inform and better inform how services can be improved, and then to continue sort of monitoring those services. And then I think really importantly is the support of young people to become really engaged with youth structures and to become able to participate in, different youth mobilization and networks of young people living with HIV, so that really, their own experiences and their own voice can be, represented at different sort of decision-making platforms. And I think we see that, increasingly growing, where the network of young people living with HIV, definitely holds a very strong position at many decision-making tables. And we need to see how we can really move that, to a local level as well, not just sort of at global or national levels. So just from my side, that little input. But then, if okay, I want to move to some of the other questions, which really focusing more on the mental health, of peers, supporters themselves. And maybe, Carol, this question best suited for you to start us off with. But, just in thinking, I mean, as you were saying, these are young people themselves also managing, lots of things going on in their own world, in their own sort of change as young people. And then often listening to, very distressing realities that other young people and their peers are being faced with. So, what mechanisms can we put in place in terms of, building their resilience and ensuring that, their mental health is taken care of effectively? And I think there was a question on whether, is there any sort of research or understanding on the impact of peer support on the mental health of the peers themselves? Over to you. Thanks.
Okay, thanks. There's a lot in that question. One thing I guess I want to say first off, and going back to Chris's presentation at the beginning and looking at mental health in general and the importance of integrating it, we did have at Jean-Peierre a controlled trial where we looked at the effectiveness of peer counselors, or CATs, and when they got the additional training on addressing mental health issues, their effectiveness, and we found a reduction from 68% risk of young people living with HIV risk for common mental disorders to a 2%, which is a pretty significant change. We also had, as part of that, though, a qualitative component to the study that really looked at the experiences of the peer counselors themselves. I'll say the papers on both of these are probably the easiest way to access them. They're on the Jean-Peierre website, which is just jeanpeierre.org. And there's the papers as well as other resources on the website. But what we heard from them is how they both how responsible they feel for the outcomes of the peers who they support, the pressure they feel from that, and then also the triggers for them when their peers are talking about being abused at home and they themselves have been, or the peers are talking about the death of a parent, they themselves have had a parent die, and their difficulties. And I think really what it comes down to is we need to provide them with trusted, build trusting relationships with them, to provide regular ongoing supervision, and not just supervision, are they seeing the right number of clients and that sort of thing, but the clinical supervision, how they're really managing their cases, but then also the mentoring and the support for themselves. What is this like for them? What's getting stirred up? The counseling for them, making sure we provide them with appropriate referral links, so they're not left out there doing these things by themselves. And so it's really both addressing in regular supervision, and we also have regular monthly CATS coordination meetings where we bring them all together and to give them a platform to talk with each other, all the counselors. So I think it's providing both we have to have mechanisms for individual support, for the individual responsibility and things they get triggered and their own counseling needs, as well as group support so that they can share their experiences as counselors, as well as ongoing trainings so that they feel like they're learning more and more how to address the various issues with viral load, with adherence, with, you know, how to explain these things, how to understand these things, so that we increase their capacity, their skill, their confidence. And so it's really addressing, again, kind of going with multi levels in trying to support them so that they feel they can adequately do their work and get the support that they need.
Great, thanks, Carol. Chris, I wonder if I could, do you want to add on to a little bit in relation to sort of how Grassroots Soccer also provides that ongoing support and really takes care of the mental health and well-being of those engaged in the program? Thanks.
Yeah, it's really nice to hear Carol explain her experiences. And just to say, we don't have, this is such an important question. When we developed our mental health strategy, we did consultations across the organization, including with all of our youth mentors, facilitators, and this was the number one issue that came up is sort of, you know, what can we do for our frontline workers? And so, yeah, we don't have it figured out. You know, this is I guess the beauty of the peer model is like they get it. They're like living it too. But then they're also exposed to the same kind of risk factors, the same, you know, lack of services, support, and they come into the organization just, you know, having gone through that themselves, you know, with whatever kind of mental health challenges or experiences they might have. So I guess one thing to think about is just, you know, are there we've been trying sort of discrete services that are available for frontline workers, in addition to like adolescents going through things like therapy. We've made that available to our facilitators. But there's just the ongoing, you know, challenges of dealing with our mental health, and you know, that fluctuates. So we're reflecting a lot about, you know, what does it mean to be together at an organization? How do we as an organization support our staff, our facilitators in the way we work and are together? And what are the limitations of an employer or a workplace in supporting someone's mental health? So I know that's not a very good answer. I wish there was like, we do this and it works, but we're really trying to figure this piece out, because yeah, it's so important. So I'm really curious. I didn't know about the research that Carol was mentioning, so I'm definitely going to read that. But yeah, we're really open to ideas for how to better support our facilitators.
If I can just add a piece quickly, and that is, there's a lot that I think we know and we've learned, but I really want to build on what you're saying, Chris. We're constantly learning. We don't have this down. So I kind of presented things that we have learned, but I think the other really important piece that we have to do in order to support them is constantly listen to them and respond to them. So as we're hearing their needs, we're developing new aspects. Things like, you know, we heard from the young mothers that they had different needs than just the cats. Then we learned so we started that. And then we started hearing from the young men, the young dads, they have different needs. And so it's a constant, we have to have mechanisms in place to be constantly learning from the adolescents who are the supporters themselves. So I agree, we too are trying to figure this out, learn as we go, and respond to what we're learning from them. So I just wanted to add that piece. So thank you.
And perhaps I can just add a quick example. So, you know, one thing that we were able to do at Mothers to Mothers that we're driving forward now is also recognizing what the different needs are that may be beyond what we're currently doing, right? So we're looking to build in a self-care strategy. So that's something where individuals can, you know, drive some of these pieces themselves with a certain level of peer support or organizational support, but they can take it beyond that. And then also looking at things like livelihoods, economic livelihood strengthening. So supporting with the setting up of stock files or BLSAs or perhaps any type of like financial skills training that can help individuals overcome certain issues in their life. You know, we have some tangible case studies where we've been able to set up some sort of savings and loan mechanism, and we've had an adolescent girl, for example, who is in an abusive relationship because her boyfriend pays her school fees, and now she's able to break away from him because she sells cakes that she bakes herself and is able to pay for her fees herself and kind of break away from this relationship. So, these are very real life stories that we're seeing that are coming from just small mechanisms that can be perhaps introduced to these peer support models, which we're currently working with at the moment.
Thanks, Jean-Pierre. We're sort of heading to nearly to the end of our session. And gosh, there's so many sorts of questions and themes still coming through. We're not going to be able to sort of cover all of them. I mean, one of the things I think, is just really, we can't sort of fix everything, do everything, get everything right all at the same time. And for all of us, we sort of learning as we're doing. And I think, the complexity and the responsibility clearly in effective peer models, is absolutely much more than one training, one this or one that. So I think still, lots of things you really have to think about in terms of, as Wole was saying, going to scale, making sure there's fidelity. How do we make sure that, the impact on other peers, is safeguarded? All of these, really quite complex things that we have to sort of all get right all at the same time, which is not easy. And then my dear friend Ruben, who I apologize, I wasn't able to get to all your questions and some of your comments, but sort of working with frontline health providers, I totally hear you. And, we are really challenged with the fact that, one of the key barriers is really just an unfriendly provider, whether you're in the clinic or the community. And, for many of us, this is sort of the center of our work in trying to really shift that and make sure that whether you're receiving services in the clinic or in the community, those services are friendly and are accessible to everyone and are always stigma-free. So, absolutely acknowledge your comments and your contribution, and just apologies to everyone if we weren't able to get to all of the questions and answers. I just want to, before I sort of give closing thanks and remarks, are there any of the panelists or speakers who are sort of dying to make one last contribution, like really short? Please put your mic off, otherwise I'm going to sort of go into closing the session. I can't see any mics off, so I think it's just over to me to really, extend a huge thank you to all of you for attending today, really for all your interest, your questions, and your participation. Just to really assure everyone that the presentations and everything will be shared by Desmond Tutu, so don't feel anxious about that. I know that there were some questions around that. I think the webinar, highlighted really the power of peers and the huge role and contribution young people have themselves in not only improving their health and well-being of their peers, but also in, their own self-care and providing a strong voice in holding us all accountable to deliver high-quality, stigma-free, adolescent-friendly services. A huge thank you to all of you, our speakers and panelists, our artists, the Desmond Tutu Health Foundation, and IRV for supporting this event. Please also know, please don't just disappear, but just as you leave the session, there'll be a really short little evaluation at the end. It's going to pop up. Please, could I ask if you could complete that? We'd be super grateful. And yeah, any of your feedback on how we can improve the sessions going forward will be really welcomed. The session has, as I said, been fully recorded, and it will soon be available to view on Desmond Tutu Health Foundation's YouTube channel. So it will be accessible to you all. And with that, and a few seconds to go, I think, until we are at the end of our session. Just, yeah, very big thank you to you all. Take care and look forward to seeing you at the next webinar series. Thanks. Thanks, everyone.
Thank you. Bye-bye.
Thanks,
Thanks.
Gwen.
Bye.
Bye.
Thank you. Bye-bye.